when you come into a patient's home, what's your first thing that you ask about the medicines? Show me your medicines, show me your bottles.
And in their dresser drawer too.
Uh-huh.
You know, because there's like a million of them in there.
Right.
Occasionally.
Over the counter, could be that, like you say, it's at their bedside, table in their bedroom because they take that one at night and they forget to present it to you. But knowing their medications, asking after we've got that initial list, what do we ask, after each visit, during each visit?
Have you had any changes to your medications? Anything added, anything subtracted, anything you just decided you weren't gonna start to keep taking? Have you developed any new allergies? Has anything changed with your medication?
Yes.
Is somebody else taking over the responsibility of giving you your medications?
Those are excellent points. And when you have that information given to you, what do you do next? Document.
You have to update their medication list, you have to do a new medication reconciliation.
Right.
And, confirm what they're telling you is true. Oh, I started these antibiotics. Really? Can I see the bottles? Oh, according to this, you started this 2 weeks ago. You should be done with this by now. You know? Verify what they're telling you. Sometimes patients are very good historians, especially when it comes to their medication.
Correct. So that's excellent points. Those are all things that will keep us correct. Medications, plus too, we're documenting that in the home folder, updating our EMR with that information, so that we have the details there. Oxygen is a medication. It should be on the med profile. If medications are not in the home when you go there for that start of care visit, what's your answer to M2020? They have 2 prescriptions at the pharmacy that they've not picked up. What's your answer to that question?
What is the question? What is showing?
I'm sorry, the medication question.
Many medications.
2020 is the first one about oral medications.
Whether they can
Take it or
manage
not.
their own medications. If they haven't picked up the medications, that doesn't necessarily make them incompetent to manage their
It does. It makes them, you cannot do an assessment, so there are 3.
Okay.
Automatically.
Always a 3?
Always a 3.
Okay.
If their prescriptions have not all been filled, because you cannot do a true assessment of their medication. Okay?
Even if they were just, the doctor called it in that morning.
Well, for start of care, if it's, all the medications are not there, there's the daughter's home. They're wherever they are. You have to answer that as a 3. So we're shortchanging ourselves on our oral medication, one of our star questions, because we're assuming that they're able to take all this, but until we know what all the medications are, that's just a give me point. You need to bank it a 3. Okay?
No, one thing, who knows what therapeutic substitution is? Who's ever heard the word therapeutic substitution?
Medication related?
Medication related.
So like instead of Lipitor, you're giving them.
So what's happening is, and you might start seeing this at NHC in the future, is if you want to chase your grandmother's medication reconciliation, your parents, yours, if you go to the hospital, if you take Nexium, the hospital might have Prilosec as the medicine that they use because it's cheap. If you take Losartan, the hospital might have Valsartan as the medicine they use because it's cheaper. If you take, like you said, Crestor, Lipitor, Zocor, the hospital might have Pravastatin as the medicine they use. So let's say that the person's in the hospital, and I do their medication reconciliation when they go home. I'm like, oh, Ms. Jones takes Pravachol, I'm gonna check that off. She doesn't take Lipitor because that's the hospital one. She takes Nexium, check that off. But let's say that somebody calls the doctor on the phone and says, Ms. Jones is ready to go, she's barking at the, she wants to get the heck out of here. Send her home on all of her current meds. All of her current meds are the therapeutic substitutions that she's on in the hospital. Those current meds are not what she takes at home. So now all those meds get sent to the pharmacy. Daughter goes to pick up all these meds. When they get home, there's Nexium and Prilosec at home. There's Pravastatin and Lipitor at home. There's all of this. So that is a big problem that we're having when they come to the nursing home, is I'm getting blamed to say, why'd you start my mom on Lipitor? She came to me on that from the hospital. I didn't change her hospital meds. I follow their hospital meds at NHC to the T, and my job at NHC is to try to, it's probably one of the only times they're gonna see a geriatrician in their life, is to stop whatever I think is inappropriate. If they take Benadryl at home, if they take Tylenol PM at home, all of those. But I think there's some medicines that have cholinergic effects that can dry their mouth out, that can cause falls, that can cause urinary retention, and I'll try to stop those as best I can, and we have a good success with that. But you have to look at therapeutic substitutions at home, because you could be seeing 2 bottles with the same type of medicine, and they're probably taking both of those. And it can happen with blood pressure pills, and that's the biggest one.
Yeah.
If they're taking multiple blood pressure pills, now their blood pressure's down, their heart rate is down, and they're tanking, nobody knows what's going on. Well, they're taking atenolol and metoprolol, or they're taking lisinopril and enalapril, and that's what happened there. So you gotta look at therapeutic substitutions when you look at your medicines, because it's really, really key. Have them show you all their pills. Have them show you all their pills. You know, one thing that I've had a home health care nurse teach me in the past is, if she's gonna go see somebody at their house, and when she makes that phone call, is tell them, say, I need to have all your pills on the table, but can you make me a list of all your pills before I get there? Ask them that on the phone. Say, is there a possibility for me to get a list of all your medicines, but can you have all your medicines on the table? Once you get there, half your work, or could already be done if you're seeing all the pills, but if they have a list for you already, put some homework on them. They have to have an onus on them themselves. So.
Very good.
And
Excellent.
Angela, everybody is responsible for documenting the meds. Don't leave it for the next person coming into the home. That's the thing that we've said. One of the things that I've noticed lately in doing a lot of the QA is it's everybody's job to do that. If you go into a home at 8 o'clock and you know your coworker's coming in at 1 and at 3, it's your responsibility don't leave it for the next person. Everybody needs to get that done when they notice it. Okay? And not only is it going to help the patient, but it's going to help build our morale here in the office. So I really, really, really would appreciate that, and I expect that to happen too. So, and really it's wearing us down in the office, getting reports of, well, this person was just here and they didn't document. I'm not going to put up with it anymore. Okay, if you see a med change, it's your responsibility to take charge and own it and deal with it. Okay.
I mean, by putting it in the med profile.
That's correct.
reconciliation, right?
That's it. Because your next person, when goes in there, maybe the patient has dementia, and when the next person says, okay, do you have any new meds?
They may not report it.
And they'll look in the MAR to see if it's been added. If you're adding it when you're there, you can make sure, it goes a long way to, ingratiate yourself to your
You
coworkers.
still want us to put like a little notation in the in-home folder so that.
Absolutely.
Yes.
And then once we get that medicine, if you're an assistant or an LPN, then Lynn or Lori or your supervisor on that particular case can recapture the snapshot. Will reprint it for you, and it'll have it in whoever's going to see the patient at the next time. Sorry to interrupt.
That's okay. Great point. Again, allergies, another very, very important part of the medication profile. Everyone now gets the H&P in the push pin of the EMR. If you see your start of care push pin, there's a little blue push pin. That is your whole H&P, your admission record, when they went into the hospital, when they're being discharged. It's your whole H&P. Shame on you if you do not do your homework and read that. That's your responsibility as a clinician to know what is going on with your patient. Your orders are in there, your history of what happened with that patient. Most of the time, medications are in there, what they're being discharged home on. You have the list. Use that tool. It used to be that was the number one complaint of home health, is having to come in here to the office every morning to pick up our start of care packets for our H&P, for all this data that we have to have before we can go make a visit. Now we've made it user-friendly. You have it at your fingertips. It's your role to push on that pen and find it. If it's not uploaded, you be calling this office before you go into that home and say, load my H&P so I can review this history. I'm not going into the home not knowing what's wrong with this patient, okay? So protect your license, protect yourself, protect our patients. Do your homework and read, okay?
Is there a way you guys can put the meds in?
No.
No.
You can't scan it in?
No.
No.
Oh, come on. No.
Half the time they don't even match, though. Their meds half the time don't even match, though, what you guys are getting sent from.
That's where
The
you do your
discharge
medication
paperwork, guys.
Good point.
reconciliation. Exactly, that's our role of doing the medication reconciliation there in the home.
The Matrix Care from NHC has the allergies on the top. And then every H&P that we dictate has the allergies in the H&P.
Yes. Don't put NKA if you do not know that there's no known allergies. Do not do that, okay? Because that's not valid information that you're sharing. Make sure you see that.
You don't know?
Well, if you don't, if you've researched the H&P, it's not listed, but I find it 99% in that H&P. You just gotta do your homework and find it, okay?
And one thing with the allergies, Angela, I want to just add how much of a strain it is on the back office. 24 485s we had to reopen because there was either no allergies and there was allergies listed in the H&P, or there was a blank. And we are really trying hard to get our claims sent out. And the way Kinzer works is if a 485 is not in sent to physician status, the claim won't drop. So then Donnie has to go through a whole list of steps. We can't reopen a ticket here or open a note here. We have to put a ticket in, and we're waiting for 75 other offices to put a ticket in, and it's just a very laborious process. So if you guys can get that done in the beginning, I would be eternally grateful, because it really hampers us, and it hampers us financially. So thanks, Angela.
Yeah. Weights are your fifth vital sign, okay? Blood pressure, pulse, respiration, temperature, weights. That should be done on every ambulatory patient. Either teach them to weigh, do they have scales? If they have scales, are they monitoring their weight in the mornings, recording that? That's their homework for you to go back in and look at during your visit to see how is their weight doing. If not, you need to be weighing them. You cannot get a stated weight from the patient on start of care. You must weigh them, okay?
So what you were providing us with scales then?
Everyone should have scales.
We've spent more money on scales in this office than everyone should have one in their
Get your scales
trunk.
for your bag before you leave here, okay?
Is it those white ones?
Yes.
That don't work sometimes?
Best practice is to use the patients, because that's what they're gonna be weighing on when we're no longer there if they have it. Yeah,
Will
okay?
you please clarify if for therapy, I know if they have a CHF diagnosis you want us to weigh, but you want us to weigh every visit regardless of the CHF
Yes.
diagnosis as a therapist?
Yes, yes, let's do that as just best practice. That way you can see, are they steady getting on the scale? Is that a safety risk, getting on and off? It's a balance issue, in doing things like that. Again, you're walking the patient and you're seeing how are they improving in their ambulation, going to the bathroom, going wherever it is on a flat surface. So please, 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 make sure we're weighing the patient. And what are we doing with that data when we're gathering it, okay? Does the patient have a 5-pound weight gain since the last visit? What are we doing with that information? Are we questioning it? Is it a valid weight? Was it the last time that they recorded? Are we doing it? Is there a difference in our weight? Again, then you have to go into your clinical assessment. Do they have edema? Is their abdominal girth swollen? How's their lung sounds? What's the difference here? What is their diagnosis? So, are they taking their Lasix? Have they skipped 3 days of their Lasix? You're gonna have to do those probing questions for the investigator. You're the clinician there. That's why you have the clinical knowledge to determine to put all those facts together to report to the physician of why the weight gain has occurred. If it is, that's a preventable patient that may prevent from going into the hospital. On the call with the doctor, they've had a 5-pound weight gain in 2 days. From the recording here, their lungs do sound like they have some rouse located. They've got 2+ edema. They've skipped 2 days of their Lasix. What do you want us to do? I know they need to take their Lasix. Do you want to increase it? We can come back on a tomorrow visit to do a follow-up. Those are the things, probing things we need to do to keep the patient out of the hospital.
So where do you want us to put that on our therapy note in the other?
And a COPD patient,
Mhm.
are we supposed to supply those scales to them?
If-
If they don't have them?
If they don't have them, yes,
Even
we
though
will do
insurance
that.
don't pay for it?
Yes, we will give them a scale if they do not have it. That's something we will do. Yes. to,
Cause that is on two of it.
Christina had a question,
I'm
Angela.
sorry.
Where do you want us to put that on our therapy note, since there's no section, just in the other, put weight and what the
Yes,
weight is?
that'd be fine, yeah, just somewhere in notation. Again, and I didn't know this until this week, in our Oasis form where the weight section goes, it only allows us to go up to 440 pounds. If a patient's weight is greater than that, we would have to put 440, and in the comments, put what the actual weight is, because it will only allow us to do that. We're getting rejections on the validation report because of a weight being entered, say
Craig Perkins,
correct,
he was 454 pounds,
and we entered that as
and
the
we entered
correct
that so
weight.
that Oasis kept coming back from the state repository. So you put 440 in the 1060, and then you document in the comments, due to limitations of Oasis, I can only document 440 and 1060, but this patient's weight is actually 454, or whatever it was.
So something I didn't know that, so,
There is a height limitation too, and I've just forgotten it off the top of my head, but it's,
okay, haven't heard that either.
Yeah.
So. Wounds, again, wounds are best practice. What is it? What's our best practice for wounds? Exactly. Are we doing that? Are we doing that? Photos once a week, measurements at least weekly. As many of our managed care patients as we have, if we're not doing that, we're doing a disservice to our patients, we're doing a disservice to our documentation, because we're not getting visits approved, because we do not have adequate documentation. Document the wounds, the
I thought
site.
they wanted that every visit now. So which is it?
You wanna do it every visit?
I don't
We were
want
just
to.
told that.
Do it every visit. We were told to do that because there's nobody doing it one time a week. So,
Mine always get done at the beginning of the week, but then I have to start doing it every single time. So.
okay, make sure, do a look back, look and see in your notes, when is it weighed? When is it measured? Is it measured? Is there a weekly measurement there? If you're the first visit for that patient of that week, you measure. Then your peer after you can look and see, did Angela measure on her visit? Then that's my measurement for this week, okay? In the home folder, you should be seeing a measurement too.
One thing I started doing is actually putting my ruler in my photograph.
it's supposed to.
Exactly, that's what you're supposed to do.
I didn't always do that.
Okay.
Because sometimes you can't hold your camera and you think,
Yeah.
and then at
Mhm.
the same time, but,
Yeah.
that's something I started doing.
And we ordered a bunch of those from McKesson. Does everybody have that little stack of, okay.
Okay, IVs, let's talk about that for just a moment, for IV infusion patients. Excuse me, everyone, so we're almost finished, let's finish up right quick. IVs, how do we deem our patient competent? Or our caregivers, when we're doing IV infusions?
Teach back, they have to teach it back to us.
Or observation of them actually performing. How many of you are giving yourself credit that you're doing that? I don't see it a lot. You're doing it, but you're not giving yourself the credit for it. Please, 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 make sure you're saying you observe the patient or the caregiver, their technique, their, of performing the SASH method of what you've taught them to do, and they're doing it appropriately, and they're competent to perform the infusion, okay? Please, please, please.
I have something to add.
Yes.
And with the IV antibiotics, be sure that you're putting the saline and the heparin on your med list.
Exactly.
Flushes.
I've got a question. There's a study that was recently out, and I'm noticing it with some of my IV patients, that they're not getting the heparin. There was a study recently saying that heparin's not always necessary.
Mhm.
So I have a patient right now that doesn't have heparin, he does have saline. So is that gonna count against us with our answers?
No,
Documentation?
Your PIC lines, if your PIC line doesn't have clamps, you don't need them.
Right.
Your PIC line has clamps, you have to have heparin. So if you get there and their PIC line has clamps and they don't have heparin ordered, you probably
Then we have to call it in. Yeah.
get it.
So those are very good points. Document who is your infusion company. Document, every visit. How many, have they missed any doses of their medication, of their infusion? Look, do you ever go to the refrigerator and look and see how many doses are left? So that you know, does an order need to be placed for their medication? if they're sending it out a week at a time. You know, so that they can say, no, I haven't skipped anything, but you see in there's 10 doses and you should only have 5. Yeah, they've missed half of their medication. So kind of look and see. Make sure that you see the emergency anaphylactic kits in the home. Are you seeing those? The epinephrine, the Benadryl. Is it in their supply box when it's delivered from the infusion company? If so, where is it placed? A lot of the places tape that to the refrigerator or tape it somewhere to where you can get to it very quickly in case of need, so that you can explain that to the patient and the caregiver of what they would need to do, okay? Any other questions about IVs or any questions that you have in general for me that I'd be happy to help clarify?
I have a question that just something else. We're talking about the saline and the heparin. If you go and draw labs on a patient and you administer 3 flushes worth of saline and 2 of heparin, you have to document that on a mark. You have to put if you gave those medications on the mark. Just FYI.
On the line, not in the
Yes.
note.
No, you need to put it in the mark. It has to be documented that you administered those medications.
Are you talking about in the note itself?
Yes.
In the drop down
Yes.
that you're administering?
Like, you know,
Mhm.
in
I
that
thought you were
section.
selecting the medication form. Because it's
Well,
already on there.
so if you,
Where it says complete
Yeah.
MAR.
yeah,
You
that's right.
have that.
Document that.
I thought you were talking about like adding it to the medication.
Well, it should already be on the
And that's why I'm
medication. Yeah.
If any of you are, I know a lot of people here are new, if there's anything that you have question about, please come see me or Karma or Lynn, from the push pin question to missed visits to doing this about our tablet. It's very, very important that you go back and read this and know what to do specifically between patients and how you're going in and going into your locator, clicking on that on each patient's home visit get as you're signing. Okay, so it becomes your signature of the patient in their home, okay? Very, very important, as well as making sure that we have set our settings correctly. So, we can do that afterwards, after the meeting, if you have any questions about that. Okay, thank you.